Thank you, everybody, for joining. I'm Sarah Jane Tribble. I'm the Chief Rural Health Correspondent with KFF Health News, and I'm a longtime member of AHCJ. This webinar is the first in a series on rural health that we hope will help you understand some of the most pressing challenges in non-metro areas. We hope you leave with resources and lots of story ideas. Today's topic is the $50 billion Rural Health Transformation Program. But first, I want to also tee up the next webinar in the series. It's about rural health, data, and data challenges in rural America. Michael Mead from East Tennessee State is a wealth of information. I've met him at lots of conferences, and you don't want to miss this one because he's really great. And if you can attend 4 of the 5 webinars and don't mind taking a little quiz afterwards at the end, you can receive a certificate of participation for the series. You can also get the certification if you do all the webinars on your own convenience and take the quiz when you are ready. Now that the house cleaning is done, let me turn to our panel. We're going to present and then answer questions, which you can type in at any time, and I will direct those questions to our guests at the end of the panel. So to begin, we have Maya Sandalo. She's Director of Health Policy at the Bipartisan Policy Center. We have Adam Searing, who's Associate Professor at Georgetown University McCourt School of Public Policy, and Katie Klingsborn. She's a reporter with WildFile, who's been doing a fabulous job covering the Rural Health Transformation Program in Wyoming. And then Kevin Bennett, he's a professor at the University of South Carolina School of Medicine and director of the South Carolina Center for the Rural and Primary Healthcare there. So let me set this up. If you haven't been covering the Rural Health Transformation Program, it's a 5-year program meant to help rural America. It passed as part of the Big Beautiful last year, which you're probably more aware of because of the Medicaid cuts in it. And this RHT, as we'll call it, was added as a last-minute sweetener for Republicans who are worried about rural hospitals and the cuts to Medicaid. All 50 states applied for the money and were approved, and states have begun handing out money to hospitals, clinics, and technology companies and others just in the last month or so. But first, why exactly does all of this matter now? We've probably all heard for ages about rural hospitals closing, labor and delivery units closing. And I just wanted, before the panelists started talking, I just wanted to make sure that there were a couple of data points that, that folks knew before we got started. So I'm going to share my screen and go over to some slides. So the first one is rural mortality penalty. So when we talk about rural America, people in rural America die younger and live sicker lives. This is some of the most recent data from the CDC. At the same time, rural votes for President Trump and the Republicans are sliding right now. So these are 2 data points that I think help set up the idea of why rural America matters right now beyond rural America and why people should be covering it. With these data points in mind, I'm going to turn to our panelists now and ask them in 1 or 2 sentences why they care about the $50 billion fund and why reporters should be covering it. Maya, why don't you get us started on that?
Yeah, sure. Thank you, Sarah, and I'm really glad to be here. I think that RHTP is an opportunity for states to test creative ideas really tailored to their communities. I don't want to bypass that it won't offset the broader federal funding cuts, and I think we're going to talk about that later, but sometimes scarcity drives pressure for innovation, and my hope is also that it will motivate different types of stakeholders to maybe work together in a state that might not have otherwise before.
Great, great. Adam, what are your thoughts on why we should be covering and why you care about it?
Well, and again, I'll just echo Sarah, thanks for inviting me, and it's a great group of panelists who I read all your articles and briefs as well, so I appreciate being here. Yeah, I think for me, it's really the interesting part of it, and unsurprisingly, it's sort of the quintessential policy and politics story. And what I mean by that is that, most people, I mean, you probably find a few, but most people do agree that rural healthcare in America could use some more funding. So it's really more of a story. Where should that funding go and this sort of thing. But On the other hand, the creation of this fund is just steeped in some of the most partisan politics imaginable. And so I think the collision of those two facts means that this is an interesting thing to look at.
Yeah, particularly going into the midterms, I would think. Um, Katie, you're on the ground there in Wyoming. Why did you decide to actually take time out of your very busy reporting schedule to do these stories?
Yeah, well, I cover health, and I I think that it's one of the biggest stories that we have is, Wyoming is the least populated state in the union. It's a huge state. 44% of the state is designated, census designated as actually frontier, which is even more rural than rural. And we have enormous hurdles when it comes to accessing healthcare, and it's getting more expensive. And so when this opportunity came about, it seemed like a good way to see, well, can we find solutions for any of these problems?
Yeah. And Kevin, last but not least, I know that you are actively working on the RHT in your state in South Carolina. Why do you care about it, and why should reporters care about it?
Yeah, I think it's an interesting opportunity. And I think, I've said it before, we have 50, projects basically. And there's a huge range of activities and initiatives across those 50 states. I think it's a really interesting opportunity to see what works, to develop really innovative models that work. There's some states that are much further along already than others. And I think it could accelerate transformation across the country if we look to those programs that work well, abandon those that don't, and try to move forward. And that's with the huge asterisk that we'll get to of all the downsides of it as well.
Yeah, yeah. So this webinar is set up as an educational webinar. You guys are getting a certificate at the end if you're listening to this. So let's dive into some of the details. I want to start with Adam and go to his Georgetown slides real quick to sort of visualize what the program looks like. So here we go. Adam, this is your slide. And it's about reducing spending in Medicaid over 10 years that the Congressional Budget Office says will continue, right, beyond those 10 years. At the same time, the RHTP is 50 billion. Talk to us a bit about why these two numbers should matter to reporters covering the Rural Health Transformation Program and Medicaid.
Well, these are the key numbers in the in HR1, or the Big Beautiful Bill, the reconciliation bill that passed last year. And the 900 billion in cuts are the CBO's estimate for Medicaid cuts over 10 years. It's actually a little more than that if you add in CHIP, and even more if you add in the some of the other cuts that are in there. But it's about 900 billion of cuts in Medicaid. And that means about CBO estimates about 10 million people as a result of that bill becoming uninsured over the next 10 years. 7.5 million of those will be Medicaid and CHIP, folks who have Medicaid and CHIP, but no longer have it as a result of that bill. And then as part of the same bill, the Rural Health Transformation Program was passed, and that is giving states a welcome $50 billion over 5 years. This is a program that ends after year 5, so it is a time-limited program, but again, welcome. And I think the main thing is just to remember that it's always more fun to talk about the interesting and innovative things we can do with the $50 billion. And I think those are good. They're good things. It's not to take away from any of the good things and innovative things that are happening, but this is all in the context of millions of people losing health insurance, health coverage, and the biggest Medicaid cuts really in the history of the program.
Yeah,
Um,
and before we go on, I just want to say, can you guys see the slides? I'm toggling between screens. So, okay, good. Thank you, Katie. I just want to make sure the audience can see them. This is your next slide, Adam, before I go back to showing the faces. But this one also goes right into what you were saying about the Medicaid coverage and who's losing coverage. And this is a comparison between metro areas and small towns in rural areas. So we're showing, what are we showing here on this slide?
Well, we work every year with my alma mater at UNC Chapel Hill, and we're just looking at what's the Medicaid coverage in rural areas and small towns compared to urban areas in the country. And it is slightly more folks and significant in rural areas and small towns who are kids and adults have Medicaid coverage than they do in urban areas. And so there is more Medicaid use in rural areas. It's not a giant difference, but it is a significant difference. And so changes in the Medicaid program will have a larger effect on rural areas and small towns.
Okay. And then I'm just going to toggle to the next one, this political debate one. And, both Senators John Barrasso of Wyoming and Senator Jerry Moran it's an interesting slide. Senator Jerry Moran of Kansas are politicians who have framed the RHTP initially as helping rural hospitals. In that political framing, Adam, can you talk a little bit about the political reality that's there? And then I'd like to ask, some other panelists to chime in on that.
Yeah, sure. I think the politics around this are what I find fascinating. I know my fellow panelists are looking at many other aspects of this, but the bill was being debated, HR 1 was being debated, these giant Medicaid cuts were happening. A lot of people were very worried about the effect on rural hospitals. Many have closed, many are under financial pressure, as I'm sure others will talk about. And so the framing of the politicians who were for passing this bill, the GOP said, well, this is a hospital fund. This is a rural hospital fund. And if you actually looked at the language did not say that that's what it was, but that was the way it was framed. This happens in politics, but it was very noticeable. And then when after the bill was passed, there was the guidance or the grant proposals that went out from the federal agency CMS put even more limitations on the fund in this, including like a 15% limitation on how much money could be directed directly towards provider payments, including payments to hospitals. And that wasn't in the legislation anywhere. So it's really the way the politics were talked about when the bill passed are very different from the implementation now.
Yeah, that's a good way to sum it up. We'll get into some of the details on what the implementation is with Maya here in a second. But Kevin, you're in South Carolina. You have been a long time rural health advocate, former president of the National Rural Health Association. When we talk about the politics and the framing last July that we were hearing, any thoughts on how that framing and what you're seeing on the ground is happening now? What's the contrast there that you're seeing, Kevin, and what should we be watching out for as reporters?
Yeah, I think it's the old phrase, everything is political, right? And this was very much so a political football thrown into the field to get the votes to pass the one big beautiful bill. I think the idea behind it is excellent. And my colleagues at NRHA have said, gosh, this would have been a good program by itself. And I think the idea of let's put some money behind transforming rural health delivery systems because they need the help. They don't have the resources and it's just not working. But the politics behind it, the way it was implemented with the other parts of the bill, it's kind of hamstrung the ability for it to actually transform. Most notably, it's basically a year-to-year program. You can't propose a program with these funds that lasts over 5 years. And institutions don't change in 1 year, especially healthcare institutions, and especially ones that are truly transformative to take us to the next step to be sustainable. So that's going to be a huge challenge. And I don't think that the political side of it, like, hey, this is going to help rural hospitals, as Adam pointed out, 15% cap. There's going to be a huge gap between what comes out of it versus what they said was going to come out of it.
Yeah. I'm going to just show this slide that Adam has here as I talk about moving on to kind of talking about the details of the program. I want to switch over to Maya, and get into some of the details. And she's got some great presentation on this. But she has, this slide that Adam has, the political debate, the 15% limit on community health workers too, the very tight timelines. These are things that we should be keeping an eye on as reporters because it really does tax the states. That is the program. I want people to see Maya's face as she stops talking. So I'm going to stop sharing and let Maya introduce her slide, and then I'll go back to showing the slides. Maya, what is this? This shows the 5-year layout that Kevin was just talking about. Do you want to talk about your slide?
Yeah, sure. Yeah, so just to kind of pick up on where everybody's left off, this is a $50 billion program over 5 years. So just in terms of the financial details, it averages out to about $200 million per state per year. And what this slide shows is my organization, Bipartisan Policy Center, put together a map that really shows the variation of the amount per rural resident per state. So because the amount is only modestly based on the rurality of a given state. There's a wide variation from less than $150 in some states to greater than 600 in others. Um, and on the left side here, these five goals, it's really not, as everybody else on the panel has already said, intended to offset those broader federal funding reductions through Medicaid. Instead, the stated goal is transformation in line with these five goals. So CMS outlines the hope that these funds will be used to deliver sustainable access in rural communities, to address the root causes of chronic disease, to foster technology innovation and workforce development, and also innovative care models. So it was really under those five broad goals that states' initial applications in the fall were organized and will be graded going forward.
Okay. And then the next slide is sort of the funding structure. So when the regulations came out, they didn't exactly match the bill itself. They went into a lot more detail. And can you kind of walk us through the funding structure that's here and how it got handed out?
Yeah, and so like some of this is in statute, to your point, Sarah, and some of it isn't. So that baseline funding distributed equally across all 50 states, that is in statute, that half of the funds will be distributed across all states with approved applications, and all 50 states' applications were approved. So every year, each state will get $100 million per year. The other half is what varies, and it's called workload funding. And that's distributed based on three primary things: rural factors, as well as the initiatives that a state commits to, and the state policy actions that they commit to. So actually, I think the next slide kind of breaks down the workload funding in more detail.
Yeah, there you
Yeah,
go.
so this is the 50% that varies by state. This first bucket, the rural score factors, that's calculated once during the initial application period.
Right.
That's based on things like the number of rural health facilities and the rural health population in a given state. So then it's really 25% that varies every year. Based on state reporting. And state reporting, as I think we'll talk about later, is due like in a few days.
Yeah, like 5 days, I think. I think they moved
Yeah,
it to the 31st because the 30th was a Sunday.
right. Right, exactly. And so really what they'll be reporting on are these two primary things, and that's what will determine future workload funding. So initiative-based factors, that basically means what do the states plan to do with the money? And a wide variety of types of initiatives that I'm sure we'll talk about today. The second bucket, state policy actions, it's not meant to actually use funding, but rather to kind of enhance the impact of the initiative-based investments.
Yeah.
Once again, a really wide variety. I can name some examples. Some fall into the nutrition bucket. So states are incentivized for implementing
SNAP.
waivers to
Yeah.
restrict the purchases of things like sugar sweetened beverages through SNAP, for committing to the presidential fitness test,
Right.
doing nutrition as part of continuing education, and then a variety of other things like interstate licensure compacts, expanding scope of practice. So BPC, in case it's helpful, kind of lists those all out in a bunch of explainers, and happy to dive into any of those details.
Yeah, yeah. And from a state reporting level, those are interesting things because the state legislatures usually have to approve those and get those through there. And the states are being graded on how much money they get from this program, if they can get those in their legislatures to approve those policy action items. Those are sort of one aspect of it, as you point out with these technical scores. Before I move on, it occurs to me that reporters probably want to know, with the new progress reports coming out, and I'm going to just put this on the timeline here. That 25% base funding, do you expect it to be stable for the next 4 years? Is that what your understanding is? Or do you think the states could lose all the money?
In terms of the part that could change every year,
Well,
just to
when they
make
get
sure
the
that I
awards
understand the
every year, and
question.
other panelists can chime in too, but when we hear of the awards, and I've got the slide up right now with the year one budget ends October
Mhm.
26th, so we're expecting those awards to be announced again for the next year. Could a state not get an award at all, or is it the belief that states will have that base funding in the coming years?
My understanding is it was the initial application that approved all
Mhm.
50 states. And so that baseline funding that's distributed equally will be distributed equally to states. And then that other 25%, so really it's 75%
Mhm.
total, it could be affected by things like not spending your funding. So we can kind of
Mhm.
talk about that. Like there is some language in the statute and in the CMS notice of funding opportunity that there's a bucket on unobligated funds that if those aren't spent, then states can't keep them. Um, and then states basically have 2 years to actually spend down the money. So there's some kind of nuance, but
Yeah.
that 75%, assuming states obligate and spend it all, isn't going to change year to year.
Right. And I see Kevin shaking his head. I just want to kind of turn to Kevin because I know you've been studying this a lot. Is that your understanding as well?
Yeah, yeah, like she
Okay.
said, there's that baseline. And I think, seeing as how this is a lot of reporters and journalists on the line, keeping an eye on reporting on the clawback, I think is what they're calling it.
Hmm.
There's a lot of debate on how aggressive that will be. The statute is pretty vague, specifically vague, if you will, about how that's going to work and how much they're going to, I guess, enact that. I think, there was concern when this was first announced that there might be biases according to red and blue lines across the states, which did not seem to play out. Um, will that happen on clawbacks or not is a concern, I think, to keep an eye on if there's any systematic bias on who gets more clawback versus others and what they consider to be unspent or not correctly spent or those sorts of things.
Yeah.
And I think if I read it right, and Maya, you can probably confirm if they do clawback funds, that means other states could get more next year as well. So they
Hmm.
could redistribute it out. So
Okay.
it's going to be interesting to see. My gut, and I hate to hypothesize anything with the politically infused process right now, is that year one, they won't be very aggressive with that at all unless it's, incredibly egregious.
Okay.
So I think they're just kind of hanging on and trying to figure out what to do. Just because the timing, I think Adam's slide said that the timing was so
Hmm.
quick for year one that they're just trying to make sure you did a few things, that you allocated it, that you've hit some milestones. I think year
Yeah.
two is when we might see a lot more of that uptick on that.
Interesting. I'm going to share the timeline again because it's really, and I think it's important for reporters to know because what the states are looking down at is they need to obligate these funds, during this first year. They don't necessarily have to spend them, which Maya said. Adam, you've been following the federal government for a long time. Is this timeline, how does it compare to other grants and other programs you've seen?
Well, it is ambitious to say the least. I mean, it's not sometimes, things get compressed, but for this amount of money going out this quickly, it's unusual. And I think it puts a lot of pressure on states to, to meet these goals and deadlines that they set in their plans they were going to meet. The only other thing I think I agree, everything with what Kevin was saying about the clawbacks and stuff, the statute itself gives almost unfettered um, control over how that process happens and how much states get to the CMS administrator. Um, and so, yeah,
In
I
other
think,
words, the CMS administrator has full control
yeah,
to
I
make
mean, it
decisions.
really, and just to note, it's non-reviewable, so you can't take it to a court, like say that's in the statute as well. So,
Hmm.
it really is up to the CMS administrator whether the states are complying with the law and if they have an approved plan, which even for that sort of equally divided up section of money is required as well. But I think Kevin's right. That it would be. I don't think they're going to try and start taking money back, especially before an election coming up.
Yeah. Let me just point out to the audience, if you want to put questions in the Q&A, we will get to them at the end. You've got some of the best experts here that you can take, and all of it's on the record. So just to put questions in and and we will get to them at the end. I'm going to share another slide right now because I think it gives you an idea of the time frame and how important it is to the states. Katie, I'm going to turn to you because these are your stories, and I'm curious. You've got one story here that says, what's at stake. I think it's from January, and if they're going to improve, rural health with these, they need to act on it. What were you seeing in January in Wyoming, and why did you write this story?
Well, yeah, so the timeline has been a huge factor here. And I will start by saying, Wyoming is a very Republican state. The majority of our lawmakers and our voters are Republicans. So I think there is an attitude where, they want to comply and they want to work within this program, but still, um, the it bureaucracies and legislation does not move fast, and we've had both in this case have to happen. So the health department, I will give them credit, they've been racing around to try to keep this on track. And there's also this criticism that it's only a one-time thing. So in Wyoming's original application, one of the main core parts of it was to create a perpetuity fund. Wyoming has other such perpetuity funds where it's managed by investments, and it would enable the state to keep funding health initiatives in the long term so that it would address that whole 5 year versus sustainable. Um, and the federal government did not approve that. So even though they approved the application, there was months of negotiation following that on the perpetuity fund, which ultimately Wyoming had to get rid of. So that even pushed us back even farther
Oh, on the
into, I think,
timeline.
yeah. So we were actually behind other states when they said, okay, here's the money. And that was like July 1st, I think, is when they opened the request for proposals for
Right.
applicants. So the state would have had to, really get the word out to these potential applicants. Like, you guys have a month to get your stuff together and get this all in. And those applications from the applicants were due on August 3rd was the last day. And then this advisory council that was put together by legislation had like less than 2 weeks to review everything and then give the money out so that it could stay on track to get it obligated by the October deadline. So, um, to Wyoming's credit, so far it is on track, but it has been stressed like throughout the process, like how much is at stake, because they think, if they don't stay on top of this, they could be looking at losing some of the money. Um, but I also don't know. I haven't, because it's moved so fast, I haven't been able to pin down any of the people who have been approved for the funds to say, like, is this a hardship on you? Have you been able to get everything you want to get these applications together? What's this going to look like?
Yeah, Maya, I just want to ask you a little bit of a follow-up question there on the obligation of the funds. This has been a big conversation that I've been hearing when I've been out reporting. So this deadline of October 30th, the funds have to be obligated by what point, and what should we be watching for as reporters? And are you here? And then just to pile on, are you guys hearing, and I'd love to hear from everybody, that states are stressed about these deadlines and getting these funds out right now? Maya, why don't you start on that?
Yeah, sure. And I'm really curious to hear from the others. I mean, yes, we are definitely hearing that states are stressed, is the simple answer. We haven't seen any announcements like publicly that a state has obligated all of their funding. That doesn't mean that it hasn't happened. We've seen lots of announcements of funding opportunities, but kind of that they're done with that process. We haven't seen those announcements. So we're definitely monitoring it closely. And yes, states are stressed.
Yeah, and to be clear, it's obligate, not spend. So they don't have to actually hand out, like, spend the money. They just
Yeah, yeah,
have to
yeah.
say promise it to groups. Kevin, are you hearing of not just South Carolina but any all who's stressed?
Yeah, I mean, everybody is. I mean, what is it? Compliance and procurement. I've heard procurement 10 times a day now, and that's a huge issue. And in South Carolina, I think we kind of had the opposite problem in Wyoming. We, you know, our ask, I think we had to adjust $60,000 over our ask. And our agency did a really great job of turning that around. They said they resubmitted it within 24 hours back in January. And we are still haven't announced awards yet. You know, it just takes a long time for these systems to work out. And so, you know, reports coming out soon. You know, they had 700 some applicants that they had to work through to obligate their 200 million. I mean, and I know they're struggling because this is 200 million layered onto an agency that, you know, they've tried to staff up to try to spend it. And that's hard. They've got Medicaid roles. They've got
Right.
all
This
these
is the
other
same
things to try
agency
to
that's
take
dealing
care
with
of.
those Medicaid changes that are coming down the
You know,
pipe.
and just
Yeah.
running the Medicaid program and beneficiaries and all that kind of stuff. So it's, I mean, it's a huge, huge lift. And so, and then they have to turn around and try to figure out what is the reporting, because the reporting is unclear. I haven't seen final guidance from CMS on what exactly reporting is.
Oh, I think it came out, but
I
Okay.
think
anyway.
just in the last few days. So
Yeah.
So I
understandable.
just haven't seen
Yeah.
it. Yeah. So,
Yeah.
Yeah.
and that's, you know, when is, you have how many days to go parse through that and get it correct and not have it reject, you know, all of those things. So yeah, I think everybody is very stressed about it.
To be clear, those reporting guidelines, Maya, I know we've been talking about them on our desk at KFF Health News. They just came out. Are those the same ones that they have to use 5 days from now? Is that right?
That's my understanding that this is the template for reporting. Yeah, and you know, they put out a draft of it months ago, so there was some sense of what this was going to
Right.
entail, and I also haven't had a chance to dig in. I'm curious if anybody has, in terms of the details. I've heard that there have been some changes, like a little bit more nuance on subrecipient and contractor reporting, for example. But yes, that is my understanding.
Yeah, we're really getting into the weeds here, and I don't want to like bore all the journalists out there. Please put questions in there and tell me if we're, you know, if you have any follow-up questions on these details. But before we leave this topic of the deadlines, because I think, you know, from a reporting standpoint, what I'm hearing from the states and from people who are applying for these funds in these states is, you know, states have to obligate these funds this year to not be clawed back, basically. Katie, in Wyoming, is the health director, have they said, are they really in fear of losing money in the coming year? Have you done any reporting on that?
They, you know, I mean, I think this came up more over the perpetuity when it was, is this going to stay in or not? I don't think at this point they are, but they have been very compliant. But I do want to just say, adding on to this conversation about stress, when this advisory panel had its first meeting, you know, just 2 weeks after the applications were due, it was the very first time they had met. So they had to do everything like appoint a chairman, you know, and figure out the rules of order. And they marathon session in one day went through the complexities of going through all their applications and does this fit, does this not? They had $17 million left over at the end because there were things that were not deemed to be fitting in the curriculum. So they had to like figure out what to do with that and where they could put that. And it was really a Herculean effort to do that in one day. And that's just, you know, one little part of this. So
Yeah.
I think that is telling on the stress of the timeline.
Okay. I'm seeing some comments, and thank you for sharing, everybody, about some of the use of the funds, right? Can you provide some notable examples of innovative proposals? What good ideas are they spending money on? I've switched the screen to the use of the funds. I think this is one of Maya's slides. And Maya, can you talk a little bit about what you're seeing, like what this slide says and what you're seeing the use, like people, how are states using these funds?
Yeah, sure. In terms of broadly the use of the funds, those 5 buckets that, you know, I talked about on an earlier slide are what CMS charged states with spending money on, but I think it's important to note what states are not allowed to spend money on. And most of these was an administrative decision. Only this bottom bucket was really set in statute that states are limited to 10% of their award on administrative expenses. That includes things like salaries for program management. But I can walk through these other buckets. Some of the other panelists have touched on them. I think this provider payment piece has made a lot of news, that direct provider payments can't exceed 15% of a state's award, and it can't be used for funds that would otherwise be reimbursable by insurance. For construction, it can't exceed a fifth of a state's award, and states aren't allowed to do new construction, so only renovations to existing facilities. Electronic health records that have already been high-tech certified, so kind of met a certain level of bar, there's a 5% cap on that. So we're seeing more states committing to kind of enhancements than full-scale EHR replacements. And then this Rural Tech Catalyst initiative is an interesting one that we can go into. It allows states to basically vet innovative technology solutions and leverages also private sector investments alongside these public funds, and that's limited to 10% of a state's award or 20 million, whichever is less.
Yeah. And I'm going to stop sharing and just ask every panelist a little bit off script, obviously. But, you know, if we want to hear about some of these exciting ideas, I know the Tech Catalyst that you have listed on here, Maya, that's something that, you know, technology innovation has been sort of a pillar of the Rural Health Transformation Program. Dr. Oz has talked about it a lot. You've heard states talking about it. The Tech Catalyst Fund is one of those. Can we just have everybody chime in on some of the ideas they're hearing out there that could be benefiting some of these rural residents?
Yeah, I think there's several kind of broad categories, I think. First, I will say National Rural Health Association has put together a nice summary of all the components of each state's plans. I'll find the link and put it in there real quick too, so that y'all can have it. And I'm a systems kind of guy, so I like some of the innovative programs around how do we pull systems of care together? How do we regionalize care? How do you get referral systems? And I don't remember specifics of all the 50 states off the top of my head, but there are some that are putting together like HR collaboratives and purchasing collaboratives across the state. That's going to reduce costs. I know North Carolina is doing a really good job with these pulling communities of care together. I think any kind of regionalization, coordinating care, that sort of thing, I think is extremely valuable. Other things to look for are payment modalities. And this isn't like the 15% we're talking about. It's what are alternative payment modalities. North Carolina, again, they're looking for a primary care capitation type payment, which is basically moving away from paying for services, but for paying for a population. And several states are doing that sort of thing as well. And I think that's where you're going to see some really interesting movement of, can we pay for rural care differently, not spend any more, but they get better care, services are maintained, local essential services are identified, robust primary care, and then regionalization to take care of the rest. And then you layer in technology to kind of facilitate it all. I think that's the ideal scenario. We're going to see some states do a lot of bits and pieces of that really well. And some states are just going to, I think, just kind of fund programs that aren't very well coordinated and everything in between. So those are some brief examples I could come up with off the top of my head there.
Yeah, thank you. And now that we're talking about technology, I want to show Maya's slide. And there was a great question from Ariel Hart down in Georgia, asking to understand the 5% cap on tech replacements. I'm not quite sure what she's talking about there, but there are limits on the technology that states can do, right? So Maya, can you talk a little bit about some of those limits on technology? And if you want me to go to another slide, I can, but I'll share this tech one for now.
Yeah, I think the primary one is that 5% cap. So if states are limited to spending no more than 5% of their funds on replacing electronic health records that have already met a certain certification by an HHS agency called ONC. And that's like the high-tech certified cap. So that's a little bit wonky, but it's a cap on electronic health record investments and replacements.
Yeah, and the idea is the federal government's already paid lots of money to help replace electronic health records at some of these clinics and rural hospitals across the US. So they don't want to spend more money on that. They want it to help the people who don't have those updates, right?
Yeah, that's my understanding. And we heard some states were a little concerned about that. It wasn't one of the most common like caps that I heard concerns about. I'm curious if any other panelists did. Because, especially for some of these innovative technologies like artificial intelligence and stuff, maybe you need really kind of more modernized electronic health record systems. But that's the cap. And then I'd be happy to walk through the types of technology investments if that's of interest on that slide.
Yeah, let's do that. I'm going to share the slide again and we can walk through those. So these are the 4 different buckets you have for technology investment.
Yeah, so at BBC, we reviewed all 50 state plans and we found that the 2 most common kind of categories of investments were in technology and workforce. So we kind of analyzed the details of those, and these are the 4 categories that we saw as being the most common types of tech investments. So a lot of states are spending money to update IT infrastructure. That electronic health record cap is notable there, really. And that's, because modern healthcare really runs on data, but a lot of rural facilities might not have the infrastructure to make sure that the data follows a patient or to prevent against cyber attacks. So states are trying to fill that gap. A lot of states are investing in virtual care, such as telehealth and remote patient monitoring, to help rural patients who live far away from the nearest healthcare facility access care kind of in the comfort of their homes. A lot are investing in AI, which is all that people talk about these days in the technology space. I think the most common one that we saw is more administrative solutions. So things like ambient scribes for clinical note taking, and those early show promise, for example, for reducing provider burden and like burnout, which is, of course, really important when it comes to the workload and workforce strains in some of these rural communities. And then this 4th bucket are these technology catalyst funds. And so that's what states can spend up to 10% on. States partner with an experienced organization of some kind, so a startup incubator, for example, to essentially vet patient-facing technology proposals. And then they can leverage private funds alongside those public funds. So a small handful, Sarah and I have talked about this, 7 to 8 or so states have committed to that.
Yeah, I've got a story coming out with the exact it's very, very soon. But Louisiana is one of those. South Carolina is one of those that have these tech funds. Georgia is one of those. So a handful, and there are limits on that. It's only 20%, I think, of the award they get in the state, or something like that. A certain percentage, no more than a certain amount that
Yeah, I
the
think
state
that's
gets
10%.
in the award. And so technology is a huge thing. I kind of just want to ask the other panelists to say if they've heard of some really cool ideas that their states are doing in technology. And Katie's raising her hand, so I definitely want to hear from Katie on that. Any cool ideas that Wyoming has?
Sorry, this is not on technology. One idea that Wyoming had, which is pretty unheard of for a state like Wyoming, was, and this was because they went out to the people and had all these listening sessions and said one of the biggest requests was to make healthcare more affordable. So the state, in its original application, proposed to have a state operated public health insurance plan for catastrophic, but that did not pass muster with the lawmakers. But I think that was really surprising and innovative, and the administrators said this is in direct response to what the people told us. So
Yeah. Is that something that experts, Adam, Maya, Kevin, that you're hearing in other states, that the states have proposed things? And we've done a bit of reporting on this at KFF Health News, so I know it's happening elsewhere. But have you heard it to be a common thing that there's a bit of micromanagement going on at the federal level as to what's being approved and what's not being approved in these applications?
I haven't heard as much from the federal level. I know a lot of the states, I know our governor's office has been very intimately involved with the application and implementation. And in our RFPs, it said they were the ones making the final decision on awardees.
Mhm.
So I think that's where a lot of it, I think Wyoming was that case as well. The legislature really played a large role. Scope of work is one of those policies that Maya referred to as, you expand that and you get more money. And our legislature took it up and didn't do much with it because that's very contentious, right?
In
Um,
scope of policy, that's when, a pharmacist can start actually
yeah,
not just
how
handing out
independent,
medicine, but prescribing
yeah,
medicine, right? Like
yeah,
that kind of
PAs and
expanding.
APRNs, well, yeah, as well,
Hmm.
yeah, just how independent can other providers be of a physician. So yeah,
Yeah.
I've seen it at a state level. The feds, I've not heard as much.
Yeah.
Yeah.
Yeah. Adam, do you have any thoughts on what you're seeing out there?
Yeah, I mean, I think early on there was some pushback from especially state legislators who were, the state administration, the governor's office was often in states, saying, here's what we're going to do with the money, because that's what, where it was coming from. And some in different states, state legislators, and Wyoming certainly an example of this, jumped in and said, wait a second, there's nothing a state legislator likes more than giving out millions of dollars, and their uh, especially in their district, but in their state it's also good too. But there was some pushback from the CMS saying, wait a second, you have to abide by what we're saying. And Dr. Oz is in the driver's seat here, so as we are, so here's what you've got to apply to. So I think there was some pushback. Wyoming, you all went maybe a little bit farther than some of the other states, but in general I think states, like Kevin's saying, have been saying we want the money, and we're willing to do what this is such a big chunk of money and can do
Hmm.
good stuff like we've been talking about, that we want to be able to, we want to abide by what the restrictions that you're talking about.
Yeah.
So,
Yeah. In Wyoming, in particular, the perpetuity fund and that catastrophic insurance fund were two big parts of your application that really held back that application, I think, from getting approved. The process was, the states filed those applications within a couple of months last year, and then they got approved at the end of December. But then they had to, like, once they heard their amount of money, they had to then file revised budgets and narratives. And I think that's the holdup that you were seeing in Wyoming. Is that correct, Katie? And now there's progress, like there's project officers that are talking with the state about what can move forward and what can, how to move those funds forward. Is that right?
Yeah. I'll be clear. It was lawmakers, state lawmakers, who said no on the insurance
Okay. Thank
plan,
you.
and then so that got taken out, and then it was the federal administrators who said no on to the perpetuity, and I think there was a process of negotiation where the state administrators tried to get that in, and they ended up having to submit a revised budget after that failed.
Okay. Okay. I'm going to put up the use of funds slide again that Maya had, just because it shows some of these use of funds. And I think some of the restrictions as well. Provider payments cannot exceed 15% is on here. And so this gives folks an idea of some of the parameters the states are working within when it comes to the program. And yeah, so I just think it's really interesting that the states are having to balance those out. Let me move on a little bit to, I think we've got about 10 minutes left. Um, I want to move on to kind of story ideas that we might have, and how reporters can find more details in their state. Um, I'm going to fast forward to another slide in case folks haven't seen it. And it is a KFF Health News slide. Um, when you want to find out what's happening in your state, it's, the federal government isn't posting the state applications online, and they're not posting the progress reports online. So what KFF Health News has done is our teams have collected these documents, and put together each state's documents that we can get publicly. We've made public requests. Oftentimes we just ask the states for them and they share them. Many states are posting them online. But if they don't, we've been doing public records requests with the help of some of you out there, actually. Um, and and then we've done this not only for each state's original applications, which you can find on our website, but then you can also find links to the updated revised budgets and approved plans that we were just talking about that the states are working on this year. So if you want to go in there and see that, I don't know, a telehealth hub has been funded in your state, or is meant to be funded under the budget plan. You can find that on those links. At the same time, I think some of our panelists, including Kevin and Maya, maybe Adam, they know of other trackers. There's trackers across the US. The National Rural Health Association is tracking some of these. Maya, you've been watching some of these funds. Any tips for the reporters out there if they have a question about what's happening in their state? Where can they look for resources?
So one we haven't mentioned is SHIVAS, which somebody remind me, State Health Value something. I always forget what it stands for. CS
Strategies. Yeah.
Strategies in there.
Oh, that's the Princeton one.
Yes. Yes. That's a good one. They have a great tracker, pulling stuff down. Like you said, NRHA has one. Governors Association is pulling together a lot of resources on things. EPC obviously is a great one. I know NRHA is looking at doing a little bit more with what they're tracking. They've built a nice big page around this kind of thing. I think if you reach out to BPC or NRHA, they can either answer it or get you in touch with somebody who can, would be my guess.
Yeah, I should definitely plug Bipartisan Policy Center's website. We have lots of explainers that are hopefully useful and are thinking about building more of an interactive dashboard. In addition to all the resources that Sarah and Kevin mentioned, NCSL, the National Council of State Legislatures, is doing some tracking, especially on the state policy actions. So that could be a good website to visit and experts to reach out to as well.
Yeah. And as far as the grant funding opportunities, different states are doing it different ways. Some states are posting them publicly online. We've got a story out at KFF Health News about that by my colleague, Ariel Zients. So if you have a question about that, I think that's probably got some links in it for you if you want to look at the states. And then some of these trackers are actually posting them as well. Katie, do you know how the state in Wyoming is posting its grant funding for folks to see?
I need to check on their website because when I wrote on the last meeting, it was like happening. They were working on an Excel spreadsheet that they were actually manipulating as they were making the decisions. And I didn't actually check to see where that stuff was after.
Yeah.
But I have a good relationship with the health department, and so I have contacts there who I just will ask, and they've been very forthright with giving me stuff so far. So
Yeah.
I haven't had to dig that hard.
And as a reporter, I've signed up for the Rural Health Transformation Program in Alaska and different states for their alerts. And I get alerts on when grants are being announced and so forth. So these health departments largely, or the Medicaid offices, are places to go, or maybe your state office of rural health is also handling some of these grants. So those are places to check if you really want to follow up on that. I see a question in the chat about workforce development, but before I ask about story ideas on it, Adam, I think maybe you can tell us why workforce development is something the states are focusing on in the rural health transformation programs and why it's important to pay attention to for the journalists. It's a great question.
Yeah, I think that is a great question. I think everybody who's on this panel I don't want to put any words in anybody's mouth, but workforce development is just the key to helping rural communities improve their healthcare systems. It's a huge problem to get skilled folks to come to rural areas and provide their expertise. The states have been wrestling with this for decades, and doing different things. North Carolina, my home state, established a whole medical school in rural eastern North Carolina to address this issue. So it's really important. I think it's one of the ways that we can really transform healthcare for rural areas, and that's why there's so much emphasis being put on it, because it's effective. When other countries do this was a huge, Australia did a 10-year effort to improve rural healthcare. They weren't cutting their main healthcare system while they were doing it, but they focused on rural workforce development. So it's consistently a very, very important thing to do.
Yeah, I'm thinking it's one of the top things in most states, actually.
Yeah.
But I mean, don't quote me on that. But my understanding is most states are doing workforce development programs. I see a couple of folks shaking their heads. If that's the case, any cool ideas that you've seen, whether it be Delaware with a medical school or something else? That's the one I know off the top of my head. But Any other things that folks should know about that you think are innovative or just build off of a program that already exists?
Yeah, sure. We reviewed at least all the initial state plans, and we saw that every state plans to invest in workforce in some way. So absolutely one of the most common ones. I think it runs the gamut from states trying to recruit and train new providers. Some states are focused even on like medical education in high school, right? Because especially in rural areas, because that's one thing that's known. If you get folks interested from an early age, they're more likely to stay in the rural community than to get somebody like moving from an urban school to a very rural area. Delaware is starting a new medical school. I think Hawaii is starting some new residency programs. A bunch
Mhm.
of states are investing in like peer support specialists and community health workers. One thing that is important to note is this 5-year service requirement.
Mhm.
So any award that's specific to an individual person and leads to some type of a degree or credential um, is tied to a requirement that that person practice in a rural area in that state for 5 years. And that's one of the biggest things within kind of the restrictions on funds that we've heard concern about, that could kind of have a chilling effect. And then I think the state policy actions are interesting to follow in this workforce space too. States are incentivized to join interstate licensure compacts to enable workers to practice across state lines. And then also, like we've talked about, to expand scope of practice, to expand things like what physician assistants and nurse practitioners and pharmacists can do in their communities.
Okay. And any other ideas, Kevin?
Yeah, I think what is interesting, I think a lot about a lot of the workforce is I'm not going to say they weren't innovative because we kind of know what works and where the gaps are. You know what I mean?
Hmm.
I think what will be interesting is to see which states do a layered approach, like use incentive to get providers out there now, and then build structures like rural training tracks or med schools or programs and health sciences in high schools to ensure a supply down the road. Um, but I think the bigger issue isn't necessarily recruitment or even placement. Incentives are great, but they last 5 years. It's
Yeah.
how do we also restructure the payment system so that they can be paid in such a way that they can stay there?
Yeah.
How do we restructure medical debt and medical education costs so they don't want to coming out with 400, 500 in debt and then going urban specialty to pay that off? Those are the foundational issues that I think some states are attacking with, I mentioned North Carolina's
They've got some
capitated
bonuses,
primary
right?
care.
Like some of these
Bonuses,
states have
but yeah,
bonuses and for rural physicians, rural
right,
providers,
yeah.
right, in
But
their plans.
but if your patient volume is going to be 30% lower in a rural community and half of them are Medicaid, that's hard to keep a practice open.
Hmm.
So how do we adjust that? And the states that are doing these value-based and other alternative payment models on top of training tracks, I think might have more success. So I think those multiplicative effects are what we need to monitor, not just the programs themselves.
Yeah. So there is a question in the comments from an anonymous attendee, and I'm not quite sure I understand the question. It says, to what extent is the structure of this law and this guidance typical of such a policy? And the reason I'm having trouble with this question is because I don't know that this such a policy has happened before. Like this seems like a very unusual policy from the federal government. And so am I right about that? Is it atypical from the federal government to pass a $50 billion program that has this sort of timeline and these sort of expectations?
I would say yes, but I'm interested in what other folks think. The other thing I thought when we were all talking about this issue, the timelines and how they want the federal government doesn't want a long-term fund in Wyoming or whatever. There's a midterm election coming up. I hate to bring up the politics again.
Mhm.
There's a midterm election coming up in November, so we've got to have these all these projects announced before in October. And I will note before we did this, I looked on the CMS website. Their first 6 news releases on their website are all about different state projects with the rural fund. Oh, we're funding this, we're funding this, we're funding this. So it's just so hard to separate all the good stuff that's happening with this fund away from the politics of it. And it's maddening to somebody who really cares about rural health because you want to be doing a great job, but also it's hard. So
In other words, you're expecting a bunch of headlines to come out in the days before the midterm elections,
yeah,
and that could be a political infusion,
right.
right?
When Kevin's like, let's slow down and think about what
You're right.
works and what we can really do for the long term. And
From a reporting standpoint, what I hear, maybe Katie can help me, is it's a very timely story.
yes.
Although you've just gone through your primaries there in Wyoming, so I don't know if November matters that much for you, Katie.
Well, I mean, let's be honest, it's a red state. So it's like, it's not really in dispute if like our primary election was, and our governor has been decided, even though the Republican candidate will face challengers, like he's going to be our governor.
Yeah.
But I think, one of the big concerns that I hear about from skeptics of the program is the potential for waste, fraud, and abuse in this very fast timeline. And I would say to reporters, like, watch the money, and try to track it and account for it. How is this really being used? And keep on it, because what if this telehealth company gets $18 million, and what do they do with it? Like,
Yeah.
we need
Are they
to,
a proven telehealth company? Have they actually done the work before? Things quite that.
Yeah. So I think it is going to be really important to track this beyond just the initial announcements and what actually is done.
Yeah, and that's why I'm excited there's so many people on the call today, because it's only going to be reporters. Democracy dies in darkness, right? Like, if journalists across the country can watch the funds and who is getting those funds and see if those are legitimate companies or not, ideally they are, right? But, money is money, and following money is kind of what reporters do. So I would encourage everybody to do that. I've got a slide with a bunch of resources on it to help you track that. And we'll be sharing the slides afterwards. But actually, what I want to do as we wrap up our time is something I had put in the notes for all the panelists. And that is, if you guys, and Katie, you just led us right into that. And that is ideas, concrete story ideas for the reporters on this call. So, Katie, you already just gave us one. If you have another one, we'll start with you, and then we'll move down the line with concrete story ideas. Other than watching the telehealth company.
Yeah. Here's another idea that's been bouncing around my head is, when the premium tax credits expired last year, Wyoming had the highest increases in the country. So people who live here, their health insurance is getting really expensive. So that is still happening. And my question is, can this bucket of $200 million, is that going to help alleviate these people who all of a sudden their premiums went up by $400 a month or whatever? And yeah, that is kind of one other thing, thinking about some of the things that maybe it is not able to address because of the stipulations or criteria that are still issues.
How are people in rural America, the people on the ground, actually seeing the money improve their health and where they're at in life?
And their access.
Yeah, and their access. That's perfect. Kevin, concrete story idea?
Yeah, I think I'd echo that. I think one thing I'm specifically trying to dive into is, where is the money literally spent? I think the technology companies are a great example. They could be an Atlanta-based company that gets all this money, and how much of that is going to be spent in the rural communities, because that could be really additive beyond improving access and care. It's an economic driver. I think kind of the other question about workforce is, how many providers are going to get into the communities immediately versus 5 years from now, 10 years from now, I think is another important story. And I think, I have a lot of writing and ranting about this, but I'm worried about all this investment in technology supplanting local in-person care. We don't need mobile hospitals for rural. We need funding for primary care, right? We need doulas and midwives and those sorts of things. And that would be interesting to track to see if there is any displacement because of the investments in technology versus people or systems.
Yeah.
Or
Although
facilities.
some states are definitely funding community health workers, right, with some
For
of this money.
sure,
So
right. But if we're using
interesting to
AI
track.
to look at claims and see what people need, that's what a CHW does. Why aren't we, let's invest in the people that can do this well and probably more accurately, let's be honest. So,
All right, Adam, story idea.
Well, my Katie took one of my ideas because she has great ideas already. So, but I think one thing that's going to be interesting is that that the cuts that are in HR1 in the bill are really going to impact rural areas in some significant ways that they, in more so than in urban areas. So the work requirements, the reporting requirements, have their special things that special barriers in rural areas, like mail service is slower, and for example. So the cuts are really going to affect rural areas significantly, and maybe more than in urban areas. And this is an administration that, like we've been talking about, is putting a lot of emphasis on how great this rural fund is, and it is a good thing. But both these things are true, and I think they're going to, as we move forward in time, where they're going to come to a head. And it's sort of, this is expanding a little bit on what Katie was saying.
And those Medicaid cuts start happening when?
Well, really, that some states are implementing the work reporting requirements a little early, but yeah, next year. So it's really kick in. Yeah.
And then Maya, I'm running out of time, and you've been so helpful. But what a quick story idea?
I feel like it would just build on what everybody is saying. So I mean, I think
Okay.
in addition to that, just tracking transparency, October is the month that we'll hear about the rescoring decision. So lots of interesting stuff to track there. And some states are posting more information than others. I did write down 3 states, Oregon, Iowa, and Oklahoma, who are good models for transparency. So those could be some good websites to look at.
Excellent. Thank you, guys, my amazing panelists. Great sources for us reporters out there. They're a wealth of information. And I want to say thanks to all of you who tuned in today. If you joined us late, you will find the recording of this webinar at healthjournalism.org in just a few hours. And once again, I want to thank our presenters for taking the time to share their expertise. And for the audience, don't forget to join us for the next webinar in the series. You can register at healthjournalism.org. It's September 2nd, and we'll cover the rural health data. Same time, same place. Thank you so much. And good luck on your stories. And thank you, wonderful panelists.
Yep, thank you.
Thank you so much.
Glad to do it.